Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one size fits all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Good morning and welcome to Talking Therapy. My colleague is
Alan Francis. Hi, Marv. Good to see you.
And thank you, and good morning to you all. And my name is Marvin Goldfried, and we're going to continue our discussion of assertiveness in therapy, which I kind of think is probably one of the most important interventions or areas of intervention that exists in what we very frequently see in outpatient therapies. The term may not ring true, but when we get into the clinical stuff, so you want to hear clinical stuff, you want to...
Yeah, and I think, Marvin, just to strengthen the comment that you just made, I think I'm a great believer in virtuous cycles, that when people make small changes, simple changes in life, it sometimes has enormous positive feedback. And results in major changes in the future. And I think assertiveness training is the best example of that. That if you help people become more assertive, and even in tiny ways, it has a tremendous effect in improving their lives.
Right. And basically, the way I view assertiveness is that the person tunes in to what they want and what they need, and has the courage and self-dignity to verbalize that to others.
In a nice way.
In a nice way. And it'll become clear as we start talking about, methods of intervention and clinical examples. So there's no one way to increase assertiveness. I mean, there's a label, assertiveness training, but it's so very varied. So there are two types of unassertiveness. One is the difficulty in saying no. Alan, I have a 1,000-page manuscript that I really appreciate your feedback on. I just need it by 12 this afternoon, New York time. So you have a few hours.
That's the only type of unassertiveness I plead guilty to. I can't.
Are you going to do it for me?
Huh?
You'll read it for me?
Whatever you say, Mark.
Okay. So that's difficulty in refusing requests that one deems unreasonable because of their life circumstance. So it's not just being nasty and being negative. It's like, I really can't do it. I have other things I have to do, but being afraid or being unable in some way, shape, or form of saying, I'm sorry, I know I can't do it. The other type is what you can think of as initiation. And this is much harder. It's much harder because when it comes to refusal, you have to respond to an external request. Whereas initiative, you have to bring it up on your own. So it becomes much more difficult. The nice thing, however, about initiation type things is like my asking you, I really need your help, is that I can bring it about and I can practice that in session because I can make it happen. I can make the circumstance happen. Whereas with refusal, you have to wait for somebody to ask you. So when it comes to working with somebody therapeutically, you have to keep in mind, are they continually unassertive in saying no, in which case you don't have to worry too much about bringing about the circumstance in their life for them to work on, because it's going to occur a lot. Did I make myself clear? Not sure if I
No,
was.
and I think it's a distinction that I find very helpful that never occurred to me before, that it's sort of like playing defense versus playing offense, that teaching people, helping people to learn both how to protect their boundaries, to say no, kind of being better at defending themselves. And on the offense side, being able to initiate contact when that's useful. I think it's a very useful distinction. I think just saying that to patients, what you just said, I think just saying that to people, it rings so true. It helps to frame the issue beautifully.
Exactly. I wish I put it as eloquently as you just did that. I like that offense defense. It really captures it.
I want you to be a little more assertive, Marvin, and not give undue credit to me. I think take credit for yourself.
Okay. So the second point that you made is just bringing it up with a patient is important. So this gets now into the whole area of intervention. Simply talking about it with some people will make a difference. Or reading a self-help book on assertiveness. And there are so many out there. The one that I continue to use is one that was originally published many years ago called Your Perfect Right by Alberti and Emmons. And I think it's in its 12th edition. It's kind of like McDonald's Millions Sold. Very, very good book, and they've updated it. So some people will read that book and they'll come back and say, oh, this has been fantastic. And it makes a huge difference. And I think it makes a huge difference because it provides the patient with a corrective experience. If somebody was afraid to say no or to ask somebody for a favor, and they haven't been doing this out of fear, say, that the other person would react negatively, and they finally manage to do it, they take the risk, and what they anticipated doesn't occur. And what occurs is something positive. This is the corrective experience. So assertiveness can be thought of as really a wonderful way for individuals to develop corrective experiences.
It's so elegantly simple. It's so easy to understand. It's so relatively easy to do. And the consequences go far beyond just assertiveness, that you develop a whole new set of relationships with the world if you're able to engage it.
Absolutely.
And many people are sort of cloistered within themselves for fear that they will offend or they'll be rejected. Once they take that first little step, the first phone call, the first engagement, so many interpersonal things open up that previously were closed off.
Right. Exactly. They feel better about themselves. They're less depressed. I've had patients who come in and relate an experience, an assertive experience that they engaged in the previous week. And I asked them how they felt. And they said, I felt lighter. I felt more centered. I felt my feet were planted on the ground. There's got to be something going on up there neurologically because it's so systemic in the way they describe it. And people who are depressed, I ask them, what about the depression? And they say, oh, I wasn't depressed. I mean, it's not a one-shot cure, but it alleviates the depression, the depressed mood.
And then they can do more.
Yes, and there's your virtuous cycle.
Positive feedback.
There's your virtuous.
You'd be able to do more, be more assertive, and engage people in a variety of other situations. And everything seems to flow like a snowball downhill once the first steps are made.
Not always. So what I'm doing is I'm giving you a yes, but. And it's when the patient gives you the yes, but after they've asserted themselves, that it doesn't fall into place automatically. With some people, they'll say, yes, but it was only one time. Yes, but I couldn't do it in other situations. Yes, but I can't talk to my partner this way. Yes, but my friend is so much better than I. So they can negate. Some people will negate that because it is so, I'm going to say a psychodynamic word, so don't get too shocked. Okay, you ready? I said, it's so ego alien that they can't process it, or it's so much against their self-schema that it's hard for them to recognize and encode it.
And it also depends on the environment and the people they're dealing with. So that with you hope most of the time that the person goes out there and takes a risk that the environment will be positive.
Yes.
Some people live in very negative environments where assertiveness is slapped down, and that makes it much more of a challenge for them and has to be done in a much more graded way. Otherwise, they'll get discouraged.
Yes, yes. And that makes it tricky, because who is to say whether the environment, who's to say beforehand whether the environment is going to be sympathetic and positive? And there's where clinical judgment comes in. Or if you're not sure, you talk to a colleague. What do you think? Or you explore with the patient. So, as an example, it's an assertive response for a sexual minority to come out to somebody else, and it feels good for them. However, under certain circumstances, it might not be advisable. So that's a tricky kind of thing. You really need to know something about the environment, about the culture, about the system in which they're living.
And it might not be the first task. There might be other assertiveness tasks that require less gumption and entail less risk.
Yeah.
Gradual, stepwise ability to be yourself more can eventually lead to the ability to really be yourself.
Yeah. So there's a domain of a person's life. Well, I mean, by domain, it's like intimate relationships or work situations or interactions with superiors or interaction with people who you are supervising. So these are all classes of situations that may not generalize one from the other, but may be important.
Yeah, and I think also that often the first assertiveness steps will be made somewhat awkwardly and hesitantly.
Yeah.
So it's useful not to go for the home run on your first at bat, but rather to work up with the ability to do things that are fairly simple with low risk, and then gradually increase both the complexity of the act and the consequences involved, both positive and negative.
You sound just like a behavior therapist.
Well, everyone has to be. I mean, any therapist who doesn't know about this and doesn't do this is not going to be doing very well by their patients.
This is called graded tasks and shaping,
right?
Where you start with a simple behavior and then you build your way up to more complex. And there are lots of individual differences with people who would benefit from increasing their assertiveness. There are some people who are just massively unassertive, who are apologetic. I had a patient who, in the first session, this person apologized for everything, things that really were not deemed necessary for an apology. And this was a very important clue. This person was clearly did not feel very good about themselves. This person was fearful and needed to recognize, become aware that they were so apologetic as a first step.
I think that's a really great point. And it again brings us back to integration of different seemingly separate schools, that what you're talking about would be in dynamic circles called transference. And that a very important part of the corrective emotional experience to increase assertiveness happens in the room with the therapist. That for many people, the very act of coming to therapy is an assertiveness task that's very difficult. Talking about yourself, very difficult thing for many people, and learning to be more assertive and more comfortable with oneself in the sessions then generalizes outside the session. So your patient, you're apologizing for everything. The first assertiveness sort of experience is you're working with her to be less apologetic with you.
Yeah. That's an interesting point, because I think a major difference between a psychodynamic and a CBT point of view is where you're looking to see the change occurring. And I think to too much of an extent, psychodynamic people focus only on the session. And to too much of an extent, CBT people focus only on what's going on between sessions. And I think that's a shortcoming of both orientations.
Let me just underline that, because that may, Marvin, be the most profound thing you've ever said.
That's nice. I have to think of everything else I've said in order to decide whether.
It goes to the very heart of the fallacy that people should learn one technique or another.
Yes, yes.
And that any therapist who exclusively focuses on the therapy relationship is likely to have patients who will stay in therapy for 20 years and maybe not get very much better. Any therapist who only does homework assignments and doesn't notice what's happening in the sessions will never really be following the patient closely and never take advantage of the wonderful opportunity to point things out alive in the sessions. Mm-hmm. Not something hypothetical about how did this happen, how did that happen, where the material always gets filtered and is never as clear cut. When it happens in the room, it has an enormous immediacy that leads to very often positive corrective emotional experiences.
Well, I have to say, Alan, that you're agreeing with me is probably one of the most profound things you've ever said.
I'll try to keep up with you, Marvin. I want to be profound, and agreeing with you is easy.
Well, especially if you're unassertive. Anyway, let's talk a little bit more about how to implement it. So just simply talking about it, or asking the patient a question. Did you ever think of saying to your partner, "I'm sorry, I can't do that, I'm busy"? Could be an intervention. It's a question, but it's I think the clinical law, it's planting the seed. It's getting the person to become aware, and awareness is one of the steps of change and can in and of itself lead to a motivation to change.
It's also not bossy.
Yeah.
And it's easy to be bossy with passive patients or experience this bossy by them. And this is getting them to be more assertive by thinking about it and thinking what might be the ways of changing their behavior without a directive.
Yeah. But it's also good with people who don't want to be told what to do, who have that feeling of what's called an internal locus of control, or is exemplified in Frank Sinatra's song, "I Did It My Way." They want to do it their way, so you don't tell them what to do. You explore what to do, and you plant the seed. So sometimes just talking about it, or during the session saying, "Well, there are any instances in the past week where you were able to assert yourself?" So it's, sometimes it's, quote, homework, a term which I hate. It's like, I'm going to give you homework, is not maybe the best way to ask a person to do something between sessions. It's between sessions self-therapy. But even if you don't suggest that they do something, just simply asking. Some people, there's an intervention method that some people use. It's very, very simple. And I think it's underused. And that's called role-playing, behavior rehearsal, where the therapist with the patient simulates an interaction that hopefully is going to occur in the next week. So it's kind of rehearsing for an assertive response in the following week. And you can do this with audio feedback or video feedback. And you can do this where you reverse roles, where the therapist serves as a model. And as you so astutely pointed out a little bit earlier, don't make it too complicated. Make it simple at first. So ask somebody, you rehearse, somebody's asking you to do something and you can't do it. And then you just rehearse saying, "Gee, I'm sorry, I can't." And the person learns not only to say it and reduce the anxiety, but also to know an effective, interpersonally effective way of saying it, so that it's more likely to result in the outcome that they want.
I really like the idea also of taping it so the patient has something to listen to during the time between sessions, both because of the intellectual value of the rehearsal, but also because it makes it more part of their outside life.
Yeah.
It serves as an icon of what they can do, and provides also maybe a magical feeling. If you have the tape, I'll be able to make this work.
Yes. And if you can even give the feedback during the session where you repeat the video, which I think you can do, or the audio, and then you ask them, what did you like and what do you want to do differently? These are very hard questions for some people to answer because they are only focusing what they dislike. Oh, I don't like the sound of my voice, or I sounded hesitant. Criticizing, pointing out what's wrong, doesn't give them a direction as to where they want to go. So the focus is more, what do you want to do differently in this next role play? So you can do several role plays of the same situation with feedback, self-feedback, and also therapist feedback. And they can see, it's like magic. They can say, oh, that's, did I do that? And say, yeah, that's you.
I think also you're pointing out how much of therapy is using the Socratic method, using questions as a way of stimulating people's ideas and emotions. Socrates said, I'm just the midwife of other people's ideas.
Yeah.
And I think that's very much the position of the therapist.
Yeah. I think a lot of CBT people don't get it. They tell people what to do.
People don't get it either.
Yeah.
What don't they get?
They don't get the need that you're saying of being Socratic, of letting the patient do the work. They'll tell them, well, you're afraid of of other people not liking you. But exploring with them, what are the fears you have? So the whole picture of assertiveness, unassertiveness, and becoming more assertive is not only changing your actions, but also your thinking, or the patient's thinking about, if I disagree with somebody, the relationship is over because they're not going to want to be with me. So it's an erroneous idea, and you can try to argue the person out of it, or you get them to do corrective experiences where they take that risk.
Yeah,
the relationship doesn't end.
It's a lot easier for therapists to say things, to be declaratory, than to be inquisitory in a clever way. So the simplest thing in the world is make an interpretation. Much harder is to figure out a question that will allow the patient to do the work that comes to the same conclusion, but with their own effort.
Yeah.
And doing it with questions rather than statements is a great equalizer. It helps the patient to feel that they have been assertive in the treatment, that it's their ideas rather than their, passively swallowing the interpretations of the therapist.
Yes. Which, in a sense, in itself is assertive. They're willing to come up with thoughts. They're willing to tune in to what they think, what they feel, what they want, and have the courage to speak up. It's so closely related to self-concept, self-image. If a person doesn't think that their thinking is legitimate, or what they feel is legitimate, or what they want is legitimate, one way of getting them to recognize that and change that belief is to verbalize it, to have the courage to verbalize it to another individual who hopefully, and again, this is risky, hopefully will say, okay, I see your point of view. That's a good point. So they're finding their own voice.
And I think that one of the ways that this can be furthered in the room itself, in the therapy itself, is for therapists to be asking for feedback from patients about what's working well, what's not working well.
There you go.
What they think is effective, what they think is ineffective, what mistakes you've made. That this is a way of giving the patient more control of the treatment. If they're unhappy with things in the treatment, they're not bringing it up.
Yeah.
That's a terrible sign of unassertiveness in the therapy. It creates a one-down relationship where the patient's afraid of the therapist, unwilling to say what's on their mind. And I think questions that open that up are very useful across all kinds of therapy.
Yeah. So whether the therapist realizes it or not, they're doing assertiveness training by asking the patient to verbalize certain kinds of things. That's a good point. And
they're inviting assertiveness on the part of the patient.
Yes.
In the relationship, in the room, where everyone can see that the consequences are not so terrible for speaking up.
Right.
And it brings the therapist down a peg. We're in this together. We're working together. I'm saying things about you. You should be able to say things about me.
Well, it's not so much bringing the therapist down; it's bringing the patient up.
Exactly.
And having respect for them. And if the therapist has respect for them, even though they were not raised that way, they can start changing how they view themselves. Before we finish, there's one other point I want to make, and that is increasing assertiveness can occur with people who are otherwise very assertive. So a vignette, this is a person, a woman who was very, very powerful and was having problems with assertiveness because she was not getting the support that she was told when she was hired. But she was very assertive in all kinds of other situations. And the question was, why was she having such a problem? And it turned out that she was raised in the South, being very traditional. And she was taught, you don't disagree with men. It's not ladylike. So here was this person who you would say is very self-assured, very assertive in so many aspects of her life, but in interacting with the men at work, she was not able to ask again for what she needed as far as support.
I have one last thing that I want to get into this. I think it's really very useful podcast. And one last thing I'd like to cram in.
You don't think our other ones were useful?
Some are better than others. This is a good one, really good one. This is golden. But how do you deal with people who are obnoxiously assertive?
Those are harder. They occur in therapy less often. They do occur in borderline patients. And no surprise, one of the coping skills that DBT has is assertiveness. It's called interpersonal effectiveness. And it involves helping the person to better get what they want. So you keep your eye on the ball. And what do I mean by that? The ball is, what do you want that you're not getting? Why are you so angry? There's the vicious cycle. Because you're not getting this. And maybe you're not getting it because you're not asking in the right way. And I want to help you to get what you want because I respect you and I think you'll be happier. You want to work on this? We can work on it.
That's a good example. Also, how about more often on the male side, the guy who's referred by his wife because he's obnoxious, referred by getting into trouble with his boss because he's obnoxious, the more narcissistic type.
Yeah.
How do you deal with them?
Again, the same thing. They're angry because they're not getting what they want, but maybe want respect from somebody else. And they're not getting the respect because of the way they're interacting.
So how do you soften them?
I don't know. You tell me.
Okay, maybe we need another session for that.
Okay. Well, we certainly are out of time, so I can hide behind the time limit of our podcast and say,
both of us can. Okay.
Talk to you next week.
Bye-bye.
Stay safe. Bye-bye.